Thank you. As far as the topic I selected is innovation through necessity, and I think the title will become evident as we move along. Now, Thursday, Dr. Andrews was here, and he talked to us about the importance of faith and family. And I've been very blessed in my career because it's a sense that any accomplishments I've made were not because of my individual abilities, but for much bigger reasons. I've been very blessed by a family that's been tolerant and understanding of me. They've allowed me the latitude to sort of explore along some of the professional paths that I've taken. My wife, Donna, who's put up with me this last 35 years of marriage, and our two lovely daughters, Ellen, who's here with us, and our daughter, Allison, who's back home with her husband, Scott, and our two grandchildren, Thomas and Eloise. Now, probably the most innovative thing I ever did was answer Richard Viller's call to come to Paris in 2008, where he wanted to found this International Society for Hip Arthroscopy. A dozen of us got together, and as I look at this picture, there's some sense of familiarity, and I think Richard perhaps had assembled his own dirty dozen. We've had a great meeting here in Cambridge, thanks to our program chairman, Richard Field, and our host chairman, Tony Andre, but also in the backyard of Ricky Villar, who's been sort of overseeing and watching everything, and Anna, our executive director, who's really been in the background keeping the glue and making this all come together. Now, we were very fortunate, I felt very fortunate that my mentor, Dr. Andrews, was here with us. He was the one who really taught me about sports medicine, how to, not only the art and the science of sports medicine, but how to treat special people like they're regular folks and how to treat regular folks like they're special people. Now, this is the country and the town where Sir Isaac Newton used to walk around, and one of his comments was that if I've seen further, it's because I've stood on the shoulders of giants. And man, I've stood on some big ones. Dr. Andrews and my father. My father was a general surgeon who said that really a general surgeon is just a general practitioner with a few extra skills. Now, he first visited England. He came over here on the Queen Mary, which is quite a boat. Except when he came, it was being used as a troop transport, moving his division over to England in preparation for the invasion of Europe. He began his medical career as an officer in the 29th Infantry. He oversaw the medical evacuation of Normandy Beach, which is an action in which they lost 75% of their officers in the first 24 hours. Fortunately, he was part of the 25% that survived. He also created a little bit of a stir during the campaign across Europe because they captured a German field hospital, and he freed a couple of German doctors so they could return to treat their own wounded behind their own lines. He was in solo practice for 50 years, and he spent his career fighting cancer, which is a much more admirable pursuit than anything that I'll do. Now, for me, I'm quick to point out to people that I'm not a hip preservation surgeon. I'm a sports medicine guy that happens to have taken care of a lot of hips. This was early in my career, back before I had gray hair and before I had to wear glasses. I'm sewing the tongue back on one of our USA hockey players who had about bit his tongue halfway off. Now, we did our first hip scope in Nashville in 1990. It was a 16-year-old kid I was asked to take a look at, had loose bodies in his hip 2 years following closed treatment of an acetabular fracture, and they were going to do an arthrotomy. Wanted to know, what did I think about trying to take these out arthroscopically? I said, I've never seen such a thing, but I thought, hey, we'll try, and as long as we don't do something dumb like cut the femoral nerve, when it doesn't work, you can flip him over and do your arthrotomy. So this is that case in 1990, and basically I used the techniques that Dr. Andrews taught me. We used shavers to clean out some of the loose bodies. A lot of them wouldn't go through a shaver, so we got our biggest cannula we could find to flush them out. Some of them were too big for the cannula, so we just free-handed them out with a grasper. But it worked. So that sort of set me on this trek, and within a few years, we'd actually shared an article that detailed the technique that we developed for doing this. We published an article that detailed the 3 loose bodies that we'd taken out in the first 2 years, because that's all we knew about. And then in 1992, this guy lands on my doorstep. He's 14 years out from a motorcycle accident with locking, catching, giving way in his hip. His studies were normal, but MRIs and things weren't that good back then anyway. We thought, well, maybe he got some kind of radiolucent loose body that we just can't see. And after 14 years of symptoms, maybe it's not premature to say, let's take a look. I thought it'd be a normal hip scope. So I figured if I'm going to scope a normal hip, we might as well make a good educational video out of it. So we set it up to film it, and this was that case in 1992. We put the scope in the hip, trying to figure out if its loose bodies are going to be normal. And what we found was this bucket handle tear of the labrum flipped up inside of his joint, which we excised, and after 14 years of symptoms, his pain was gone immediately. And that's when a little light went off in my head and said, you know, there's other things in the hip that we're just not very good at diagnosing, and that sort of put me on this track to decipher what goes on inside the hip. Now, as an aside, 20-something years later, we coaxed this guy to come by to see me. His x-rays are still normal, and he's pain-free after a pretty extensive labral debridement. So debridement is not always a bad operation, but that's a point of a different story. We published our experiences. We started to see some of these labral lesions, and especially the elusive nature of how they can be hard to diagnose. Now, in 1994, I operated my first bona fide athlete. This is one of our top collegiate basketball players. Got undercut his sophomore year, landed on his hip, had pain. He's a month before his junior year. His hip's still hurting him. The only problem is he can't dunk, and a 6'7" basketball player that can't dunk isn't much use to his team. Three MRIs show atypical AVN. We thought, well, whatever it is with the mechanical symptoms, we'll take a look. And I remember I was sweating this one because I didn't know what we were going to find. His trainer's looking over my shoulder. And what he had was this unstable articular fragment that he'd sheared off the medial side of his femoral head, which we excised. And within a month, he was back playing, and that year he was a league MVP and league leading scorer. Went on to a successful NBA career that was ended by a foot injury, but not because of his hip. His recovery is certainly much more a reflection of his ability than mine, but simply plucking out the fragment was effective. Later on, we published our description of this unique mechanism where they fracture the articular surface on the medial side of the femoral head. Now, in 1996, this is a high school football player that I've been treating for 2 years since an acute avulsion fracture of his AIIS. He develops limited internal rotation, persistent pain, so finally we're dealing with this thing, and we decided here we're looking anteriorly from inside the joint, and we just kind of work our way outside the joint. We're doing basically today what we call nastabuloplasty, recontouring, moving the bony overgrowth with correction of his impingement. Now, in the first edition of our textbook on operative hip arthroscopy, we wrote about impingement, but we were very specific. These were post-traumatic impinging osteophytes. We were completely clueless about the role of FAI. Now, in 1996, this gal gets referred to me. She's got this clicking in her hip. And we looked at her, and really it seemed to be more the iliopsoas tendon than the joint itself. So we ended up doing an iliopsoas bursogram, and under iliopsoas bursography and fluoroscopy, you could see the tendon flip along with the click, substantiating the diagnosis. We injected cortisone and anesthetic. She got relief for a while, but came back. So this is a sort of person, well, maybe she's a candidate for an iliopsoas release. I'd never done such a thing, but I read the work by Bill Allen talking about an anterior approach. So we went in using an anterior approach, released the iliopsoas tendon, corrected her snapping, and she got better. We'll come back to this patient later on. Now, in 1997 is when the Houston Oilers moved to Nashville and became the Tennessee Oilers. For the first couple of years of the Oilers before they became the Tennessee Titans. And you can see the date up there, July of 97. So sure enough, first training camp, one of our linemen is getting in trouble with left hip pain. We inject his joint, get him through the season. At the end of the season, his hip's still bothering him. So I'm looking at scoping this guy's hip, and I'm thinking, great. This is going to be the shortest NFL career ever, because how is it that the only Yahoo in the league that scopes hips just happens to have somebody on his team that needs to have their hip scoped? Well, anyway, we bit the bullet, went in, and this is a posterior portal going in, and all this cartilage debris. And you can see he's got a lot of wear in the joint, especially on his femoral head, somewhat unique, but we cleaned it up. Prompt pain relief, came back to be a starter. Then I presented this at the NFL Team Physicians Society, and it really wasn't until years later I figured out that it wasn't that I was the only guy in the league that had somebody on their team with a hip problem. There are lots of players in the league with hip problems. We just weren't any good at diagnosing them. Now, as an aside, my nurse Kay talked to him on Thursday, and his left hip's still not bothering him. He said, in fact, his right hip's starting to bother him. That's 18 years later. I would have never thought that hip was going to hold up for 18 years. Now, in 2001, remember that patient with the snapping iliopsoas tendon? She comes back to see me 5 years later. She says, Doc, my hip problem's back. And I'm going, oh, my goodness, what are we going to do now? And I examine her. Her iliopsoas isn't snapping. She's got buttock pain and sciatica. I said, that's your back. Go see the neurosurgeon. So 3 neurosurgeons later, she shows back up to see me, and they said, they all say it's not my back. It must be coming from around the hip. And we know that when you're treating somebody with a problem, it's their problem until you operate on them, and then it's your problem. So it sort of forced me to sort of delve into this a little bit more. And we finally figured out that what she had was Piriformis Syndrome. So we're talking about maybe doing surgery for Piriformis Syndrome. And actually, we had her come by to take this x-ray the day of her surgery. And if you look at the date on the x-ray, I don't know if that date means anything to anybody, but we watched the Twin Towers go down. And that John Carlo was visiting me in Nashville at the time. He got a little longer visit in Nashville when all the air traffic got shut down. So we watched that, and then we went down and operated on this lady. We used this somewhat less than minimally invasive approach for exposing her piriformis. These are the pictures that John Carlo took. We identified the sciatic nerve, the piriformis, released it. And when she woke up in the recovery room, she had some post-surgical pain, but the preoperative nerve pain that was plaguing her was gone. And that's kind of what struck me, that for the right selection, this may be something to do. Now, I've not hung out my shingle as a piriformis surgeon, but we've had enough of them that would eventually cross our way by default that we did publish our technique, our results with this technique. Now, in 2002, this 16-year-old girl gets referred to me with clicking in her hip. She'd had two open iliopsoas releases that had failed to solve the snapping. And when I examined her, it's kind of snapping like an iliopsoas, but it's not exactly like an iliopsoas. It kind of snaps more when she walks than anything you do lying down or examining her. And she was sent because they decided she had this OCD lesion in her acetabulum, and maybe that's what was causing her symptoms. I say, well, I'm not sure, but maybe it makes sense to go in and take a look. She was kind of at the end of her rope. So we looked in there, and we saw this fairly innocuous recess, which definitely wasn't contributing to her symptoms. And we later, based on this case and others, described this as the supraacetabular fossa. We first described the supraacetabular fossa, actually in the German literature, an article that Michael Dienst had gotten me to write. And it's really a normal variation we see in teenagers, and even people in their 20s eventually fills in and becomes what Richard Villard described as a stellate crease. Just a normal variation. So for this girl, we look in her hip, didn't find anything. I'm like, well, I guess we ought to go down and take another look at this iliopsoas. So we went down, re-released her iliopsoas, took out a couple little ossifications that had developed, and this is my first endoscopic iliopsoas release. But this is probably the first operation of this type that I did that I'd actually seen before, because I'd seen one a year before with Tom Sampson and Victor Elisalituri down in Mexico City, where they did one together, and I was there. They were in Victor's new hospital, this brand new operating room. The only problem is they didn't have air conditioning in the operating room, and I'm sure Tom and Victor both remember that day well, because I did. Now, we'll come back to this case later on. Shortly after we just accumulated a few cases of iliopsoas releases, and we reported our technique. Now, we know that in 2003, Professor Gons published his landmark article on FAI as a cause of hip joint damage and early onset osteoarthritis, because prior to that, FAI had only been described as an iatrogenic process from overcorrection of dysplasia with a PAO. Now, sort of kicking and screaming and doubtful, I came into the world of arthroscopically addressing FAI, and this is a case in 2004, a 38-year-old gal presents to me, terrible bilateral hip pain, terrible motion. They told her, you probably do better just to have a hip replacement. She's got this spurring, and I'm like, I don't know if we can help you, but at age 38, maybe it makes sense to try this first before you relegate yourself to an arthroplasty. So we went in arthroscopically, and here's her labrum, which is kind of beat up. There really isn't much labrum. It's mostly just bone, a little thin wafer that we cleared out. So I'm like, well, what do I do with this? Our articular surfaces weren't bad, so I just started grinding out this labrum, and I'm like, man, this is horrible. She's going to be miserable. She's going to hate me. This will never work. Well, we ground out this labrum. When she woke up, she was so pain-free, she couldn't wait for me to do her other side. Well, we stalled for about 4 months. I just want to make sure that she wasn't a little too enthusiastic that we'll see every now and then, but she's done quite well. And this was kind of the sentinel case. It's kind of kept us looking that there is a significant subgroup of impingement with this, what we've called adult-acquired pincer impingement from labral ossification, the captured hip. Our paper on this is just waiting to be published in the Arthroscopy Journal. Now, it took until 2008 before I had the courage to inflict this operation on a child. This is my first child. This is a 14-year-old girl, a gymnast, clearly getting into trouble with her left hip. She's got significant asymmetric cam lesion. She's got an ossification pincer lesion. She's lost 30 degrees of internal rotation in her left hip compared to the right. MRI shows labral damage. So this is the sort of case that, to me, The consequences of not doing something I felt had exceeded the consequences of what might happen with the operation that I was going to put on her. Now, this is back in 2008, and for this girl as a gymnast, she's not interested in going to the Olympics, but getting a scholarship to college is going to be her meal ticket because her dad's a janitor and her mother works in the post office. They don't have any money, and this was actually back before the FAI was approved, so back then it was a cash-only basis. So this is a little girl we did for free because I didn't want anybody to think that I was profiting from operating on this little girl. But we went in arthroscopically. There's the articular delamination, tells us she's getting into trouble from cam impingement. You can see the labral failure that tells us she's getting in trouble from pincer impingement. We removed the os acetabulum, did our acetabuloplasty, then restored the labrum. Then we go to the periphery, and here's the cam lesion. Pretty good looking cartilage covering that, but it's all got to go. And you can see the little remnant of the growth plate as it tapers down what created the cam lesion. Now, purely for purposes of disclosure, I did get paid for this operation because her dad was a welder on the side, and he made this lamp for me, which resides today on my nurse Kay's desk. Marie, I don't know if you've seen that before, but you'll have to look at it next time you're there. So I did get something that does bring a smile to your face. Now, this is what we're seeing these days. This is the kind of case I'm doing at least one of these every week. A 16-year-old girl with a 3-year history of right hip pain. She's no longer doing gymnastics or cheering. Her mother brings her in because she won't go shopping because her hip hurts. She's had 3 stone-cold normal MRIs. She's got some modest pincer morphology on her x-rays, positive temporary response from an injection, but after 3 years, how long do you let it go? There's a lot of this around. Here we're looking at her. Her labrum's not torn, but it's draped out over the pincer lesion getting crushed. The labrum has such a dense neural innervation. The labrum is a very hardy structure, so it'll literally hold up for years, painful from getting crushed before it ever starts to tear. And this is the kind of case we corrected her pincer lesion, restored her labrum with very predictable pain relief, but ultimately what we're hoping is that somehow for this young girl, we're improving her long-term outlook, and it's going to be a long time before we can state that we're altering the natural history. Now we've presented our data. It's being submitted for publication where we looked at our first 100-and-something adolescents with a minimum 2-year follow-up. Now in 2009, this 17-year-old dancer gets sent to me because she's having a right hip problem. They diagnosed her with an osteochondral lesion of her acetabulum. You can see the defect up there. Well, I'm not getting fooled by this. That's a supraacetabular fossa. That's not her problem. Now, looking at her x-rays, she's got this overgrowth of her ischium because she had a hamstring avulsion fracture 3 years before that had filled with some hypertrophy, but she's also got significant malrotation of that whole hemipelvis. On exam, what she's got is Piriformis Syndrome type findings. Now, we spoke to the open surgeons who said, you know, we can go in and shave down that ischium. We have to put a fat graft between it and the sciatic nerve, so hopefully the nerve won't scar down to it. It's something we have to offer, but if you've got something else, that might be better. Well, we injected her piriformis under CT. She got better for a while, but it came back. And I'm thinking, well, maybe we could release a piriformis, but it didn't make any sense at all to subject her to this kind of exposure just to snip a tendon with the idea that we might have to come back and use the same exposure for more extensive operations. So I spoke to her and, more importantly, her mother about that, you know, maybe it makes sense to take a look in there endoscopically and see if we can release the piriformis. I said, the main thing is, I don't want to damage your sciatic nerve. If we get in there and it's not working, we may just bail out. But if you're okay with that strategy, I think it makes sense to try, and they were for it. So this is my first endoscopic piriformis release. That's the tendon running vertically. Medial is at the bottom of the screen. We're resecting at the myotendinous junction. We debride the stump back to its insertion. There's always that fibrovascular band. I used to call it fibrous band, but Hal Martin's convinced me that it is a fibrovascular band. But here's the nerve we decompress, and you can tell that was a pretty unhappy nerve. So that was my first one of those. Now, subsequently, we've described our methods for accessing the subgluteal space, but really Hal Martin has led the charge on this area. Now, also in 2009, this 16-year-old girl shows up to see me with this popping in her hip, and it's really a grating noise. It occurs at the end of the stance phase of gait, and you follow her down the hallway, and you can hear it and you can feel it, but it's hard to tell where it is. It's definitely not the iliopsoas. I thought maybe it's a posterior aspect of the gluteus maximus. We got an MRI, and she's got this tons of edema in her quadratus femoris, and that was exactly when the article came out talking about ischiofemoral impingement in the radiology literature. So we're thinking, well, maybe that's what this is, and we injected it under CT guidance and some relief, and she was really at the end of a rope after several years of symptoms. So I said, well, we'll go in, and what we'll do is we'll decompress the quadratus femoris. That's what we've got here. Now, Mark Safran, at the same time, we'd spoken because he had one of his lacrosse players, a girl with this. He resected the lesser trochanter, which I did not think was a good idea because you're risk sacrificing the iliopsoas tendon. And in most of my patients, the ischiofemoral space was normal, that just the quadratus femoris was beat up. So here we've decompressed this. We'll look back at the sciatic nerve. And we've done less than a half dozen of these cases, and our results have ranged from okay to no good at all. So not an operation I've been very enamored with. Well, in 2009, remember that girl back in 2011, this girl comes back. The girl back in 2002 that was my first endoscopic iliopsoas release. Well, 2011, she comes back, and her snapping has come back with abandon. It's miserable. She's terrible. She's done fine for over 8 years. And we look at her, and to me, she's got this popping when she walks, and it's kind of atypical back then. And now, to me, I think this is ischiofemoral impingement, but she thinks it's her iliopsoas tendon snapping again. We got an MRI that shows some edema in the quadratus femoris, and I thought, well, okay, maybe this is one to resect the lesser trochanter on, because if it is the iliopsoas with a 3-time loser, maybe resecting the lesser troch is the next step. And if it's quadratus, if it's ischiofemoral impingement like I suspect, well, this will carry me down the path that Mark had told me I ought to do back a couple of years back. So we went in down on the lesser troch, and here's the lesser troch, a little bony over. They just resected the lesser troch, prompt resolution of her symptoms. And we've now done this a handful of times on some other ischiofemoral impingements, and this has worked very effectively. So I've kind of gotten over the concern about compromising the iliopsoas if it's the operation that has the best chance of helping. Now, also in 2011, this a 72-year-old gal that's referred to me by an orthopedic surgeon that I've operated on, and she's got a big old tear of her gluteus medius. Now, historically, I ran the other way from gluteal tears and lateral hip pain because they're old people, they're miserable, they're hard to sort out. If I thought somebody needed surgery, I'd try to punt them up to Brian Kelly at HSS and not let them get in my door. But this guy goes, listen, you'll operate on me, why won't you operate on her? So sort of begrudgingly, I said, okay, well, I'll operate on her gluteus medius. So this is my very first gluteus medius repair. Sort of a sleeve avulsion, a big tear. Very amenable to double row fixation. We've used 3 doubly loaded anchors, place our proximal row, tie those down, and just like we do for anything else, we use a knotless device distally to create our double row fixation. Prompt resolution of her symptoms. And really what I've found, because now we're publishing our 2-year follow-up on these that we've done, that yes, they're older people, and yes, they're severely disabled, but they'll be one of the happiest patient groups that you'll ever encounter. The results are great. So it's really opened up a new area that it was there the whole time. I just wasn't very good about seeing it. Now, what I've shared with you is just scratching the surface of the number of innovations that are out there. We've pretty much solved as far as being able to restore the labrum. We're understanding the role of labral reconstruction. We're starting to appreciate the importance of capsular management, sometimes capsular preservation, just to mention a few. But I think if you're talking about innovations, you have to mention Mark Philippon, because Mark has clearly been the greatest innovator in hip arthroscopy. He pushes himself to do better, but by his example, he also pushes the rest of us to try to stay on top of our game. Now, as we look at these innovations, we don't do them in a vacuum. We really depend on our industry partners as we're going through this, because it's the technology that industry provides for us that allows us to develop these techniques. But that door doesn't always swing just one way, because oftentimes our industry partners are pushing us to do a better job and devise new things. So it's great that in our environment we can share and collaborate with our industry partners. Now, lastly, in closing, I would just like to comment that I'd like to acknowledge Lisa Donnelly, who for almost a decade has clearly set the bar on immersing herself into everything relative to hip arthroscopy. I think her presence will be with us for a number of years to come. And with that, I'm done. I'm very happy to be able to turn it over to Mark Safran. I know Mark's going to do a great job. We're in very good hands, and greetings from Nashville, and thank you very much.